going on. So thank you so much for joining. I'll give it about another 30 seconds as we get more people logged on, and then we'll get started. All right. Welcome, everyone. Good afternoon or good morning, depending on where you are. Thank you so much for joining us today in the third of a series of webinars put on by Genetic Alliance to uplift the findings and recommendations of the National Academy's report, Newborn Screening in the United States, A Vision for Sustaining and Advancing Excellence. I'm Natasha Bonhomme, founder of Expecting Health and Chief Strategy Officer at Genetic Alliance. And again, I welcome you to this third in a series of webinars. The purpose of this webinar series is really to present to the community at large findings of the NASEM newborn screening report and to provide an opportunity for discussion. Today's discussion is going to focus on the research paradigm in newborn screening and really what the report highlights in terms of the needs for research for the future sustainability and improvement of newborn screening. We will start with a presentation from Dr. Wendy Chung, who will be discussing the recommendations of the report. Following her presentation, we will have three respondents, Dr. May Baker, Dr. Erin Goldenberg, and Carmen Trupek. I will give a more detailed introduction to our respondents a little bit later on. But for now, I'd really like to introduce Dr. Wendy Chung, who is a clinical pediatric geneticist and molecular geneticist, and is the chair of pediatrics at Boston Children's Hospital and Harvard Medical School. She directs NIH-funded research in human genetics of many conditions and has identified over 60 rare genetic conditions. She leads the Guardian study to expand newborn screening for genetic disorders and advance development of personalized therapies for children with these conditions. She was on the NASEM working group that wrote the newborn screening NASEM report. Dr. Chung will give a 15-minute brief overview of the report's recommendations to help level set this conversation today. So with that, please take it away.
Great. Thanks, Natasha. So going through this, I'll say that I'm really speaking on behalf of the committee, and I'll be able to show you all of their smiling faces at the end, but just say that I'm representing the committee as I'm going forward with this. Let's see, make sure we're going forward. So as Natasha said, this is the third in the series. The QR code is here for those that are interested in being able to hear some more. I'm not going to go into detail on that, but rather to pick up where others have left off. So just to make sure we are level set in terms of doing this, and I'll try and emphasize a couple themes. We really are talking about public health newborn screening, and again, focusing on the research aspects of this. As we think about this as a nationwide process with about 3.6 million births per year, we are identifying currently through the newborn screening system about 7,000 babies who benefit from the intervention, and that's per year. So as I think about oftentimes in the rare disease, we're better together. And that comes, I think, especially with some of the things we're going to talk about. While they're individually rare, they're collectively more common, and being able to think about also better together from a nation, from a country point of view, how we can do best by kids and future generations by working together as we do all of this. The tenets as we think of this really are the original tenets that we think of from a public health point of view, which is that we do think about things that are serious, where there's a time urgency to be able to do this, and where they're treatable. Those interventions are effective. But I do think, and I'll emphasize that we do need to keep watching and collecting data from a quality improvement point of view to see what we can do better in terms of improving those interventions, those outcomes, those accessibilities, that timeliness for everything we do, quite frankly, in newborn screening. And as we do this, we really are thinking about this as a system. So emphasizing that it's not just the test, it's really the systemness as we think about this whole process. And again, from an implementation science point of view, how do we make sure that any cracks within that symptom are something that we can plug those holes and we can make sure that we're supporting everyone as we're doing this. Fundamentally, that does require data and it requires a research infrastructure to continue that quality improvement process. And that's a lot of what we were thinking about. So in doing this, why did we do this? Just briefly, Department of Health and Human Services had asked the National Academies to convene this committee. So that's where the call to the mandate comes from. And specifically, we were called to examine the landscape of currently of newborn screening in the US to recommend options to strengthen that public health newborn screening and establish a vision for the future of newborn screening. I'll show you again the 14 members of that panel, but I also want to emphasize in addition to those, and this is always true of NASM, incredible staff that were also staffed to be able to do all of this. And I just want to call a shout out to Kate Bowman and Emily Packard Dawson, really key members of the group as well, who kept us together and kept us moving forward. It was a wonderful group that had complementary expertise. And I think this is another theme as we think about this. We need people with many different perspectives and backgrounds coming together. And we definitely had that on the group. But I also want to say that it had broad input from over 600 people, several listening sessions. CZI actually supported some additional public engagement that really, I think, strengthened the recommendations. We were able to hear many perspectives from many people and come up with that sort of comprehensive thinking about this in the study, in the report. So fundamentally coming out of this and boiling it down to what we needed to do, but also focusing on the research aspects. We weren't as specific in terms of saying we must do exactly this and exactly this way. We didn't really dictate that, but more thinking about a framework and thinking about that we did need to have some other group would need to come up with really a strategic plan. But in coming up with that strategic plan, so we didn't set the strategic plan itself, but saying that one needed to be set, that we needed to think about this in terms of an opportunity, that there really was a moment in history, an opportunity, there's timeliness to be able to do this and to do this in a coordinated manner and to do this, as I said, across the country, realizing that there are synergies in doing this. In doing this, I will say that we wrote the report before decisions were made about the ACADUNC, and so we did not modify the report in response to that. And so there may be recommendations, and I know many communities are thinking about this, about how to respond to that disbanding of the ACADUNC. There may be things that are done that were not included in terms of the scope of our report and going forward. As we're doing this, we really were thinking about, again, how do you do this so that all the boats are afloat, being that tide in terms of thinking about the research infrastructure to do this, not just for one conditions, but for many conditions, to think about the emerging technologies, the new technologies. And although we did think specifically about DNA sequencing or even genomic sequencing and doing that, I'll say it's not limited. New technologies are not limited in terms of thinking about that. And as we're thinking about, especially some of those new technologies, how do you have standards in terms of ensuring what's always this need to optimize sensitivity and specificity? And as we're doing this to make sure that we really are equitable in terms of thinking about so that we've got excellence in the programs we're putting forward, that it's scientifically robust as we're doing this, but that as we're doing this, we constantly, as I said, have this quality improvement so that we're really thinking about this from the point of view of population health. And as we do this, it's an iterative process. And that's always been true for newborn screening and especially new technologies, but we have to be mindful and intentional to set up that infrastructure for that. We were also very mindful of what we all know from newborn screening. When you start to go in a population-based method of ascertainment, you realize you don't know what you thought you knew. And I think because of that, it's so critical that we go eyes wide open to be able to understand that and build that infrastructure to continue to realize that we thought we knew was not really what the world is in terms of population ascertainment and population structure. So in other words, we see the tip of the iceberg currently in terms of clinically diagnosing the most severe individuals. I will actually put in a modification based on some of my own experience that we even miss, though, what I would argue are the most severe cases that may not get to us clinically because they die. And so I do think, although we see mostly the tip of the iceberg, we may even be missing some of the most fatal cases. What we do miss, though, is what's under the water, under the surface. Those individuals, for whatever reason, that don't get through, don't either navigate themselves through the clinical system through various different methods. So they're symptomatic, but they're not clinically picked up. And of course, what concerns us about that is the timeliness of being able to make the diagnosis at a time when the interventions can be maximally effective. However, and this is important, when you start doing that population-based screening, how many people do you pick up with whatever that assay is who are asymptomatic and will continue to be asymptomatic? And so as we think about treatment and not over treating, not burdening people who don't need to be treated, how do we really understand what that natural history is when we have that population-based ascertainment? And so as we think about that research infrastructure that we put in place, how do we ensure that we can actually follow those individuals over time, given that we don't know much of that natural history currently? And so as we think about this, as I said, being mindful of how to do that, and I do think there are economies of scale, there are synergies in terms of doing that across conditions, but what we do have to do is make sure that we continue to improve. As we heard back from parents, one of the things that many of the rare disease advocates and community, I think we're continuing to educate each other and think through the process as we're learning through this, is this chicken and the egg dilemma. I think the community's been quite excited about the possibility of now thinking about being able to treat and intervene at a time when we can actually have a tremendous impact, that is for many individuals before damage has been done to the body. But there is this chicken and the egg when you don't have treatment yet. When is the right time to start introducing screening, and when is good enough treatment to be able to start warranting adding something to a recommended screening panel? And there's a dialogue I think that we need to continue on. And I think it's wonderful that we're able to have that dialogue, but that is part of the dialogue that we're thinking about. Within this, as we're thinking about this, we have this definition that we need to come to consensus on in terms of screening, diagnosis, and treatment. And again, who needs to be treated in what way? That is, they may screen positive, but how do we confirm that diagnosis? And then what is it that pulls the trigger in terms of starting those treatments? As we think about the laboratory testing itself, how do we have as much confirmation as we can? I would argue rather that whatever we can do on the dried blood spot before we call parents in terms of confirmatory secondary testing, orthogonal testing, any of those emerging technologies we can do to maximize sensitivity and specificity and minimize false positives is good. And within this, as we're thinking about this specifically around some of the issues with DNA sequencing, come up many of the ethical, legal, and social issues specifically around privacy and what may be more information than just what's reported out and what happens to that information over time. And that may be part of our discussion today. So as we're thinking about this, we need to think and have a longer time horizon for this and realize that it will take us some time to develop this and to be mindful and honest with the public and the community about what it's going to take before we can actually start something on an implementation point of view, going from research to implementation. So as we think about this, building a network is one of our major recommendations. That is, we can think about doing this strategically, effectively, hopefully more efficiently. And the follow-up in terms of doing this is an important part of this. And patient advocacy groups play a vital role in terms of being able to both create the ecosystem, think about what matters to families in particular, as we're thinking about outcomes that matter, and being able to make sure we build something effectively as we go forward. Genome sequencing, I'll just say very briefly, and I won't go into the technical details, but we are cognizant of the fact that this can be done in a small scale or a very large scale, anything from individual mutations or individual genes to even whole genome sequencing. And as we think about this, as I said, depending on what one chooses for that readout, there are different issues in terms of privacy and different complex issues that come up. As we do this, it also brings up the issue of our ability to interpret that information accurately and at scale. And again, different variants in the same gene even will have different penetrance, different natural history, and different need for intervention or not. And that's something we have to learn from the process. So as we do this, we do need to think about what this all means ultimately for families, individuals, those babies and their families, what that means in terms of their experience, and ultimately making sure that we're maximizing the good that can come out of this and minimizing the harm that hopefully it is minimal, but that could come out of this as we go forward. So with the genome sequencing, even though it's a different platform, just like tandem mass spectrometry was a different platform, it's really the same goals, the same tenets. It's just a different lever that can be pulled to achieve the same outcome. And so in thinking about that, we want to be able to keep that, again, timeliness, urgency, and importantly, ability to treat. And so as we do think about that, think about how to do it, and I'll underscore this, responsibly. That is a major, major portion for the public trust in terms of being able to go forward with this, making sure we're responsible for anything that would go forward. So in terms of thinking about some of those key questions, there is really a research agenda that we need to think about, and various different groups are doing this even around the world, which is wonderful. We were focused more on the United States as we're thinking about this, but how can we do this with everything from technical aspects of data generation, variant interpretation, doing it for everyone as we do this, thinking about, again, any of the concerns that might be raised in terms of privacy issues that come forward. If this is a first-tier test, what might be second-tier test as we go forward, and then some unusual issues that come to how to support this, funding issues, resource issues in terms of how to be able to do this, because this does become an issue when it's not just state by state, but potentially where federally or nationwide there's more power in doing this together. So many different ways of being able to access the information. NASM has been putting this out as we do this. And again, just thanks to all of the many talented members of the committee and the members of the NASM team that supported this as well. And for any of you who haven't read the full report, here's where you can access it.
Great. Thank you so much, Wendy. So now we will turn to our three respondents for their 5 minutes, only 5 minutes, reflections on the report's recommendations based off of their expertise and their experiences. We first will have Dr. May Baker, who is professor in the Department of Pediatrics and director of the Newborn Screening Laboratory at the University of Wisconsin School of Medicine and Public Health. Dr. Baker practiced medicine before being trained in both biochemical and molecular genetics. She has more than 20 years experience in routine newborn screening with a specific interest in applying emerging technologies in newborn screening. Dr. Baker served as a member of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children from 2016 to 2021. Following Dr. Baker, we will have Dr. Aaron Goldenberg, who is professor and vice chair in the Department of Bioethics at Case Western Reserve University. He's also director of the Case Western Reserve University Bioethics Center for Health and Genomics. His work has focused on ethical, legal, and social issues associated with research and clinical care for rare diseases and the integration of new genomic technologies into research, clinical, and public health settings. Dr. Goldenberg is also currently the co-chair of the Ethical, Legal, Social, and Policy Implications Subcommittee of the Association of Public Health Laboratories. And then we will also have Carmen Trupek, who currently serves as the Senior Director of Scientific Programs at Global Genes. In this role, she works directly with rare disease patient advocacy communities to develop and advance patient-focused therapeutic research strategies. By background and training, Carmen is a clinical genetic counselor. She has worked in both academia and telemedicine, where she developed multiple rare disease sponsored genetic testing and counseling programs to supporting clinical research. So I know that's a lot of background on our speakers, but I wanted to showcase really the different perspectives and expertise that we will be hearing from in this section. So with that, May.
Thank you. My 5 minutes done now. Um, so I think I just amazing to listen Dr. Chen describe such comprehensive report in the 15 minutes. And I think she mentioned some the concept of intentional. I think every word she said intentional. I even want to go back listen again. And I think the with my 5 minutes, I just want to emphasize a couple things she already did. I just want to emphasize. So the one part I want to emphasize is the laboratory testing and the emerging technologies. So I think come to this, we spend so much time and the discussion is we really treat this as a tool. And as Dr. Chen mentioned that conceptually it's nothing different than the tandem aspect, but they have a unique aspect. So we think of the tool and we are the ones use the tool. So we can, the technology, the capability doesn't mean we cannot do the intentional use. And I will use the words, the target application. And in our report, we also use the responsible application. So we need to understand that it's the data, it's a different information. And we need to utilize, try to take advantage of what can help us to make our testing specificity and sensitivity to the point we want good and try to avoid certain the downside. So that's, I think it's up to us how we utilize that. And so I think it's to me, it's quite how we utilize that. And I think interesting is another thing I think is the publicly, when you talk about the genome sequencing, they immediately think you have all each person's genomic information, which is not true when we apply in newborn screening. So it's up to us how we, not just education, how we communicate to all the stakeholders, because our intention is keep the principle as Dr. Chen already evaluated, urgency, severity, and treatability. We, based on that, we select a disease, we select a gene, we select the gene variants. I think it's terribly important. To me, is we talk so much about the newborn screening, it's a risk assessment. The risk assessment, if we have a new modern emerging technology, make this risk assessment even better, why we not go there? So another thing I think to me is important is the certainty. So what do? We want to help the clinicians and families have a better certainty instead of create more uncertainty. To me, that's a kind of couple important concept. The second one is I want to emphasize, we are talking about the research. I think give this context, we are really emphasize implementation research. So I think it's very interesting is we really want to see how these things apply in the public health realm, what we need to learn. You know, we understand all the disease severe, where only newborn screen allowed us to see the spectrum. So what we intended, what we not intended, what we expected, what not expected, I think we do need study, do need the relevant research to help us understand so we can maximum utilize whatever present to us. So I'm going to stop here. Thank you very much.
Great. Thank you so much, May. Aaron.
Fantastic. Thank you to all of you for having me. It's exciting to be able to talk to you a little bit about things from the ELSI perspective. So not surprising, my comments are going to really kind of focus on where I think the committee did a fantastic job in recognizing the importance of integrating ethical, legal, and social implications research and scholarship and thinking into kind of envisioning the future of newborn screening. In the past, LC research has tended to be very separate from other kinds of newborn screening research. So you have your newborn screening pilots, you might have research to look at new technologies, and then over on the side, you may have an LC study here and there looking at public attitudes towards newborn screening or patient narratives around newborn screening. And one of the things that I think the committee did especially well is recognize the essential need to integrate ethical, legal, social, equity implications research into the rest of the newborn screening infrastructure. And so I think where I wanted to start my comments is that I think any infrastructure that looks at developing a nationwide research agenda or a nationwide research network for newborn screening must treat LC research as part and parcel to all of the other research questions. They can't be considered separate. They can't be a side note or a secondary note in the kinds of work that we're doing. So if we think about a pilot study to integrate a new technology or a pilot study to look at a new condition, it's really essential that some of those ethical, legal, and social issues are part of that research, whether that's through patient narratives, whether that's through surveys, whether that's through public engagement, whether that's through talking to other stakeholders. I think we can do a better job at integrating that LC research. And I think that was one of the big points of the committee's recommendations, is to really kind of hone in on what are the ethical, legal, social issues that need to be just absolutely essentially integrated into newborn screening research. That may mean revisiting some of the early justifications for statewide newborn screening, right? We think about the ethical principles of child welfare and of the harm principle and all the various things we talk about on many of these calls, um, which were developed in the 1960s and 70s and altered a little bit over time. But it may mean that through our research, we have to revisit some of those essential questions around ethical justifications, for example, for mandatory screening, for state powers in terms of running a newborn screening program. And so I do think that any research moving forward will have to kind of confront some of those questions of, do those original ethical justifications of newborn screening remain today? And I think that many of them may. I think it's just time for us to kind of revisit those. Some of the concerns around privacy, some of the concerns around use of data and samples are not just coming from one community or one particular racial and ethnic group or one particular political group. They're across the spectrum. There are concerns about storage and use of samples, concerns about consent and privacy, and we need to be thinking broadly about what it means to address these ethical legal issues across all communities. A couple of things I wanted to just mention in terms of what some of those issues are. Of course, privacy concerns around the storage and use of data. One of the questions raised by the committee, and one thing that I think we will need to be talking about, is newborn screening is a little bit of a paradox when it comes to equity. On one hand, incredibly equitable system. All children get access to newborn screening. It is really a place where there aren't very many disparities in terms of access to the screening. But if we think about newborn screening as a system, and we think about newborn screening as something more holistic than just the screening itself, we see lots of different kinds of disparities in terms of access to diagnostic services, access to treatment and other interventions. And I do think that the committee recognized in something that we'll have to do in our research, which is to raise this really important question of, if we think we have an obligation to provide screening, what is our obligation to provide care? What is our obligation to provide follow-up services? And that's going to be a really essential part of the kind of work we do. And then, of course, the 10,000-pound elephant in the room is consent. And at what point do we need to be starting to talk more about consent in newborn screening as it relates to adding new technologies? How do we maintain the benefits of the program if we were to implement consent for some types of screening? And what are the ethical and legal thresholds for thinking about that? Those will be essential questions too. And then finally, I want to kind of say something that the committee talked a lot about, which is importance of maintaining trust. And some of you maybe have heard me talk about this before, but in the world of kind of trust and medical research and trust in medical care, there's been a shift away from one of trust to one of trustworthiness. That the burden shouldn't be on the communities in which we serve to trust us. The burden is on us to become trustworthy as researchers, as clinicians, as public health officials. And so I think a lot of our research and a lot of our work needs to focus on what does it mean to be trustworthy and how do we maintain that trustworthiness as a public health program. Ultimately, ethics is about values. It's about public values, it's about professional values. And I think where we need to be going, where I think the report does a really nice job, is to say we need to integrate those values into anything that we're doing in the future of newborn screening and really think about what those values represent and how do we address when there are disagreements among those values, whether that's between families and the program, whether that's between researchers and the program. And I think we can do that together. So I will stop there.
Great. Thank you so much, Aaron. And next we have Carmen for your response.
Thank you so much. I'm really here. I did not serve on this committee. I'm really here because I talk to so many of the patient advocacy communities that do get involved in these conversations and that feel very strongly about newborn screening and have gotten involved in trying to advocate for their diseases. And I think it's as I read the report, I was really struck. Both Wendy and May already talked about these 3 core ethical principles of newborn screening of a condition being serious, urgent, and treatable. And when I look at the research that has happened over time with newborn screening, and then I compare that to the reflections of the patient communities, I think all 3 of these come up in opportunities where research into particularly the use of genetic testing. And I know Wendy pointed out that this isn't all about genetic testing and that technology, but in particular in the communities that I work with, I would say that this is primarily what we're talking about is, the use of genetic testing for newborns has really shown us that genetic testing can be used to improve and expand newborn screening in several ways. One, it can detect disorders that fit these very classic definitions of a newborn screening condition, but don't have a biochemical marker. So SMA is a perfect example of this. Menkes disease is a disease that, I know a father who works here at Global Genes with me very well, and he's talked publicly trying to advocate to get Menkes disease listed on the RUSP. There is an approved therapy, but it only works if treatment starts in the first month of life. So this gets a little bit to what Aaron was talking about in terms of we have pretty amazing equity with the initial screen, but the follow-up and getting to treatment is an opportunity there. I think the second way I think about, these technologies improving or expanding, I'll say, newborn screening is around the detection of disorders already agreed to be appropriate for inclusion with the ones that are missed. So when Wendy showed the iceberg, these are the babies that are getting missed that we don't want to miss, and you need research to show that, right? So one of the conditions that a patient community that we work really closely with is the homocystinuria community. And homocystinuria was added to the RUSP decades ago, but there are at least 9 atypical forms, including the cobalamin disorders. And many of those kids get missed with current newborn screening programs. And it's really wide, ranging how good and not good different state programs are at detecting those. So you have people in that community whose children were detected at birth through newborn screening with one type, and who have, and then in another state, you have a family whose baby died because they were not detected. So, this issue, which was addressed in the report, of course, about trying to come up with, better standards nationwide for this is a critical piece of how this research, I think, folds back in. And then the third one, which is maybe the one that's a little bit challenging to our current system is what is our definition of treatment? So, if we can really expand the utility of newborn screening to many, many programs by thinking about the definition of treatment as as what can be a documented medical intervention. That can include things like seizure management, which can have downstream fewer hospitalizations. It can have really significant impacts on a long-term outcome. And, we work with literally hundreds of rare disease organizations that focus on neurodevelopmental disorders, which Wendy knows 100 times more about than I do. And I see her shaking her head about the seizure control bit. But getting those kids diagnosed really early, and getting them diagnosed in a more equitable way than often happens today, because we can reach everyone, I think has enormous implications for what we can do for children in those communities. And, there are hundreds known, there's probably over 1,000 really, neurodevelopmental genetic disorders with seizures as a primary feature. There's so much opportunity here. But that's a pretty massive expansion. So I didn't really pay attention to time, but I suspect I'm about at time, so I'll stop there.
You're all good. Thank you so much. And thank you to all three of the respondents. So we will now enter our Q&A portion. You can either submit a question through the chat or raise your hand, and we will call on you to speak. But we already have a couple of questions that have come in, so I want to dive into those first. One was that, when listening to the presentation by Dr. Chung, it wasn't necessarily clear what the committee thought in terms of where screening, public health screening ends and where diagnostic and testing begins, kind of the medical side of things. And that's probably because it definitely isn't a clear cut, exactly a handoff. But I was wondering if either Wendy and our respondents could speak to that in terms of, well, one, for those of you who are part of the committee, where that conversation went with the committee, and then for Erin and Carmen, kind of your views on that and how that kind of distinction plays into this larger conversation about newborn screening. Where is it going and what we need to be considering? So maybe I'll start with Wendy.
Yeah. So I think that handoff clearly, within the current programs, there are follow-up programs. And I think we realize even in the current system, our long-term follow-up for individuals is not very good. Even I would argue our short-term follow-up in many cases, and understanding where people drop off to getting that diagnosis, like a confirmatory diagnosis, and then what I call onboarding to care. We see big differences in terms of length of time it takes for that. And that's what we need to be able to study. I don't think we've got great data even for now, much less when we start adding to this in the future. So we didn't, I think each state, each program sort of defines where they officially say that handoff from the follow-up program at the state versus their centers of excellence versus their individual clinicians. But and it is to a certain extent a continuum to make that handoff a nice, sort of warm handoff as we're going forward. But within this, I think none of the programs have great long-term follow-up in the way that we'd like to. And that's the kind of infrastructure that I think we envision from the committee, and not necessarily a bright line in terms of where that handoff is, but simply it's a continuum and we need to know how the children are doing long-term.
Anyone else want to comment on that?
May, did you want to? I'm happy to.
Yeah, I can just add in a couple of things. I think if I heard the question is another thing is because the more emerging, more modern technology we use, and I really help us to make this risk assessment better. And so kind of comes the way, it's like if you have a Delta 508, homozygous, you have disease. So this really is a screening or diagnosis. I feel like if we think about the newborn screening system, if technology allowed us to do that, I think it's okay. You don't have to. I like Wendy used the term warm handoff, right? So the things that can be utilized. Another thing in recent years, I feel very strongly is when the clinician have encounter with the family first time, the more information in their hands, the better their counsel family. And to me, it's the certainty, uncertainty. You can help family. I think is useful. And I said that I use SMA as an example. So yes, screening, if you find that the exon 7 homozygous deletion, you're down. But I think SMA2 copy numbers, you have 2 and 5, the outcome is very different. I feel if laboratory can, and why not? So that's the way I see it.
I'll just add that, so APHL has some recent data showing non-white families getting diagnosis and interventions 2 to 3 weeks later than white families. I think we can't have it both ways. We can't, on one hand, say newborn screening is a system and then not attend to the diagnostic and at least the treatment initiation process within the work that we're doing. And so I think we, need to do a better job as a community in thinking about the disparities, the equity implications, to not attend to that diagnostic process, that treatment process, and what that handoff looks like, how to create as seamless of a handoff as possible. Families, we can very easily compartmentalize public health and clinical work, but for families, that's not what that compartmentalization doesn't exist. It's all part of their journey. And the newborn screening community needs to really make sure that we're attending to that journey, especially as we expand and especially as we start thinking about genomics.
Great.
I'll just add one quick thing, a little bit in follow-up to what May said about education, right? That the more education that the physician, that the family follows up with has, the better that tends to be for the family. I think in this vision that we have, some of us have, for the expansion of newborn screening in ways that really go beyond what it has been historically, that's going to become more and more challenging. And especially as we look at variability within diseases. So we see this in Pompe disease now, that the vast majority of states are now screening for Pompe disease, but there are the rate of children picked up with what's classically been called late onset Pompe disease, who typically don't develop symptoms in the first year of life, or at least overt symptoms in the first year of life, is about 10x the really severe infantile onset form. And it's led to a real conundrum for families and providers about what to do in those situations. And so the families with means will often then travel to one of the big academic centers for an in-depth evaluation to determine, like, is my child subclinically affected? You, as the expert, what do you think about the initiation of treatment or not? And those who don't have those resources just sit and wait. So there's work to be done for sure.
Great. Thank you so much for those responses. We'll go to the audience. Dean.
Good morning. Good afternoon. Thank you for this discussion. I look at the clock and we have 15 minutes to solve all these problems. We're in trouble. But I love that we're having this discussion. And frankly, it started with Aaron's, my interest here started with Aaron's comment that we need to go back to kind of the basics of newborn screening and what are the ethics and the foundations. And to me, that's the Wilson-Younger criteria. And then we moved probably more in your face to Carmen's comment about, well, what if we screen for things that have treatments, not just things that have FDA approved therapies, but something that you define as a treatment. I go to the doctor when I don't feel good, or my kid, and one of the doctors on our board always says there's always something you can do for a family. You may not cure the disease, you may not be able to stop all the pain, but you can, I don't know, help them in some way. And I think that brings, this whole conversation needs to continue. I think it's broader than just the NASEM report, but it opens the door. And we're talking about the sequencing as a new tool that will perhaps enable a lot of this discovery. And I just encourage us to keep this conversation going. I think the ethics and the tools, and then the boundaries, which is what's happened in the last 5 minutes just these comments. This is historically, it's newborn screening. It's not newborn diagnostics. but it's crept over into diagnostics. And as we talk about the handoff, I'm all in favor of good handoffs. But there's a time when I go to my doctor and she my GP is a she, and she refers me to my cardiologist. She says, not my deal, right? And I think we need to be thinking about where those boundaries are and do they need to shift, but not feel like newborn screening has the whole process. It's a start to the process. It is not the culmination of the process. So more conversation. Looking forward to it.
Great. Any comments on that?
I'll just say this is a place for great research questions and research questions that have not been asked sufficiently, and thinking about what do families envision as the utility or the usefulness or the impact of this information, and what does it mean to maybe not have a particular curative treatment but be able to get better physical and occupational therapy, speech therapy interventions. The Secretary's Advisory Committee was starting to talk a little bit about, before they were disbanded, expansion notions of utility and expanded notions of family benefit, what family benefit really looks like. And at the committee, the NASM committee talked, I think, Wendy, you can fill in, talked a little, a lot about kind of what does benefit look like. And I think it's important to continue that stream of research.
Yeah, I'll just say to continue the discussion that we're clearly in a moment of flux in terms of gathering the research and being able to implement that. And I think what I keep thinking is how can you build a system that you can adapt and readily take the research findings and move them into implementation as quickly as possible, rather than having this be a stepwise thing where we can do the research and it's 20 years later before we do the implementation. So, and the treatments are going to change over time, the supports, the whatever we want to call, but all of these. And so we need to be able to be nimble and take these learnings and implement them. And so I think we need to be forward thinking as we have this. And I think we have a real opportunity. So I think we need to think about that. And as we strategically decide how to do this, make sure we have latitude to be able to be potentially all inclusive, but then follow the data as we go forward and gather that data.
Great. Thank you so much. Another question that I had that has also come up is, we know the conversation will stick with genomic newborn screening, but what other areas do you see as being really primed for expanded and coordinated research per recommendation 8? What needs to change, or what could be the biggest boost to making that happen in a successful and sustainable way?
I don't mind jumping in. I'm the new technology nerd, so I'm going to say a couple of things. So even genomic itself, I think in our report, we indicate not just gene structure. We need to think about gene modification, and the genetic words we understand, methylation can change. This is just a very, very, very small example. So I think actually in the way is with the genomic technology involved, we can look beyond only gene structure. So that's one comment I will make. And the second one is, I think in recent years, we heard of the genomic or proteinomic and metabolomic and even peptides. I think to me, the conceptually is you have a molecular etiology. You also know the genetic defect, how the consequence, if you put something like this together, can be so, so powerful.
Great. Any other comments on that before I turn to Lynn? No? Great. Lynn?
Hi, thanks. Just a few quick reflections, and it's really building on what Wendy had added, but from some of her very early points to what she added, and I just saw Sharon's point, so it really wraps it all together. I think we really do have a lot of knowledge and a lot of research. Some of it has been misinterpreted. Some of it, we keep on asking the same questions for the last at least 40 years that I've been involved with newborn screening. And looking historically, we've said the same thing over and over again, as you all know. We need the education. We need to start early. We don't need more research to say, do we need to do that? We we've been saying it. Annis and Faden in the early 1980s was saying it, and such. We need to actually have the action plan and build forward in terms of meaningfulness. And we do in the clinical domain ask families what's important. You know, for many, our outcomes for therapies, if it's being asked what is meaningful to the family, it's not necessarily something that clinicians or public health workers would have normally thought of. It may be just being responsive to the family, smiling. You know, it may not be walking a mile. The thing is, you have to always ask that question. And I really think we can do this in the public health sector also. It's not necessarily needing to do 1,000 studies. We have some of the information. It just has to be nimble and going back and forth and moving forward, because it is a system. And even in families that have the means to access clinical care following a newborn screen, there's not the clinicians, there's not enough people power to actually see them for any of the lysosomal storage diseases, even in the best centers. So we really need to capture and obviously have funding for all of these concerns. Thanks. And thank you to everyone on the Academy papers and then some who really participated to move this forward.
Great. Any comments or responses?
I'll just throw out, I see some things in the chat and responding to Lynn and responding to some of these other comments. So, I mean, I really am incredibly hopeful that we have these opportunities. We have these opportunities also in terms of being able to get the right care to the right kids, even for rare diseases. We've got telemedicine now that we didn't have as robustly as we do now. So we have more in terms of access to care, just ability to do better things, the things that are meaningful. I think we've got beyond just genetic therapies. There's so many other ways in which being able to support those young people as they're growing up, and I call it bending the curve, but things that we can do to improve outcomes that I do think I'm tremendously optimistic about. I will say though, and this is just me personally, this is not the report, so full disclosure, this is now I'm going sort of off script here. The thing that has challenged me from as we've been doing some of these pilots and looking at it is there certain conditions where you really do need to know within the first few days of life. And that's really in terms of newborn screening and the whole infrastructure and how that's set up. And there are a lot of things that we want to get to people, but you don't really need to know them in the first few days of life. But getting that information back, whether it's a true positive or false positive, has a big impact on those families. And that's the thing, I'll be honest, that I struggle with in terms of thinking about how to do this well and the opportunities, but that, you know, doing it when a baby is 7 days old, that's a lot for the families to handle. And I keep trying to balance, when do you want to do that and how do you want to do that? And for some of the things we mentioned, Pompe's, and whether it's infantile Pompe's or later onset Pompe's, that's just paradigmatic to me of what that is. SMA to me is a different story. Like we need to get that in. Like I think days actually matter for the type 1 babies. So I don't think there's any question of SMA and the workflow and how we've done that. But other conditions, everyone is different. And how many are like infantile Pompe's versus adult Pompe's, 1 to 10 in the ratio and other things. We've got to learn and figure this out. But that's personally, as I'm watching our families and how they're dealing with this, the thing that strikes me in terms of how do we be family centric in doing that, truly family centric, and how do we design that system with all the complexities as we're learning how to do this. So if anyone figures that out, I think that's a really important thing for us to solve for as we go forward.
Yeah, we can do that in the next 7 minutes.
I would just very quickly just add that, you know, Wendy, your comments also make me think about the need for us to, this is going to be maybe controversial. I don't know if it is or not, but in addition to siloing out screening and diagnostic odysseys or screening and treatment, we also silo prenatal and postnatal genetics and genomics. And your comments are exactly why I think we need to, as a community, be talking about and talking with our prenatal colleagues about what education looks like prenatally, about what potentially screening looks like prenatally to provide information for postnatal action. Again, families see this as a continuum, not as a bright line between their postnatal and prenatal care. And I think it's an opportunity for us to get together and think about how do we best serve families so that we can act quickly and get those kids into treatment and into support and care as quickly as possible.
I really agree with that comment about the prenatal versus postnatal in terms of the education, but also Wendy, like what you were saying about these windows of opportunity. It's such a critical piece of the education, and yet I can still remember like it was yesterday. My best friend's daughter was she got that phone call through newborn screening, but it turns out it was partial biotinidase deficiency. Like it's fine, right? Her daughter takes a little biotin, always has. She's totally fine. It's nothing, and but she didn't feel that way when she got that phone call, right? And if she had to wait for follow up because to get into an appointment because that was considered low risk, even though it was picked up on newborn screening because it's a high risk condition. Like that's such a nuance that's difficult to get across to families. I don't have answers. I just agree entirely that that's a big challenge.
Yeah. And I think it's so important for us, something that is nuanced to us who are in newborn screening all day, every day, and compare all these different conditions. It may not be nuanced to that family. It is the event that has happened to that family. It was the thing that changed their story from going one way to another, even if there was support and all of that. So I think this is really a great conversation. And those of you who know me know how passionate I am about prenatal and connecting the dots there. So thank you, Erin, for bringing that up. And there's been some nice conversation about that in the chat. So I'm skimming through the chat now to try to pull some questions before we get to a close. And one was, wondering if the committee had discussed where the appropriate place in the system is for long-term follow-up and how that should be taken. We know that there are some projects currently being funded through the federal government looking at long-term follow-up. Different states are testing some things out, but really trying to see if the committee had any in-depth discussion about that. And, is it the responsibility of newborn screening programs to hold that? Or are there other agencies? And layering into that is, the concept of mission creep has come up in a couple of times in the comments. So just throwing that out there as we get closer to the close of this session.
So the committee didn't actually say where it should be. Again, a lot of what we did is to say that there needs to be a strategic plan and a group needs to come together and map that out and think across the agencies in terms of that organization, but to acknowledge that it absolutely is necessary. I guess, again, I'm optimistic without getting administrative in terms of where that sits. There are so many economies of scale to be able to do that for individuals who want to be able to share the data and making it patient family centric in terms of the outcome data that we collect, that I'm very optimistic that it can be done and it's more cost effective if it's done across states and across conditions. And I don't know, maybe that sounds a little bit too, I don't know, audacious to be able to go forward, but I do think those systems can be put in place, like I said, to be able to make it easy for people. And I think that's what we want to do. We want to be, respectful of how they want to engage, but hope that we don't leave anyone behind so that we can really understand what that experience has been.
If I may, I adding on one piece, and we did talk about the federation of the data because we dealing with the real disease. No single state can get everything, so we need a system so we can put everything together.
Great, thank you. With the last minute or so that we have, I would like to ask all of you, as a final 30-second, 1 minute closing in terms of your thoughts. We've talked a lot. I feel like we just keep opening Pandora's box more and more. We open the box and we're like, oh, there are more boxes. Let's open those. But, you know, this report has been out now for a couple of months, and really from each of you thinking about, you know, what do you hope we could really accomplish at the first year anniversary of this report, and how feasible is that? So you could go super pie in the sky, or, you know, be more focused in what you think is feasible, what's already happening. But, you know, for the conversation that will happen in May 2026, what do you hope to see in that?
I'll say very briefly, I hope that the strategic plan that we had called for actually comes to fruition, that there is actually concrete steps moving forward to make it a reality with specificity.
So I just follow what Wendy said. I want adding on that quickly is based on that, and I want to see some truly newborn screening ecosystem, and kind of address. We talk from the data for the federation part all come to some kind of centers to support our routine newborn screening, so we're able to elevate everybody at the same time.
I'll just quickly say that I think it's easy for us to say that there's lots of barriers to implementing this because of all the changes at the federal level, the lack of support, the dismantling of the committee. But I hope that this actually gives us an opportunity to rethink some of those collaborations, some of those opportunities to bring parts of the community together in really unique and new and powerful ways, bring in more advocates and families and researchers, and really rethink what the community looks like together, and how to push forward, and how to really revolutionize in really collaborative ways. And I hope that while this is a challenge and it is a barrier, I hope this gives us the opportunity to really do some amazing things based on the committee's recommendations.
Maybe I'll just add a tiny bit to that because that's very similar. What I was going to say, I think there is an opportunity to rethink, with that being disbanded. It's sad, but also an opportunity. I guess my hope is that in that opportunity, the new envisioning through the strategic plan will come up with something truly different and innovative that tries to create more consistency across states. I think we just have to start there before we think at a significant expansion beyond, when we're missing so many kids state to state already.
Great. Thank you. Thank you for all of those comments. And I agree with all of them, and particularly when thinking about that strategic plan, to make sure that it is truly reflective of the broad system and not just from one lens or another. So thank you so much to Wendy, May, Aaron, and Carmen for your thoughts and your perspectives on this. And thank you to all of you for joining us today and at the other sessions. It is just so critical that our community can come together and really discuss these issues. It's not always going to be an agreement, but we really believe you move further forward when everyone gets to have a seat at the table and be able to discuss this. So thank you so much. And in the chat, if you would like to see the other webinars, there is a link there to the YouTube playlist. Thank you so much, and have a great rest of your day.
And thank you, Natasha, for your leadership in newborn screening all these years.
Have a good one, everyone.
Thank you.